and thank you for joining the Superior Health Quality Alliance Roundtable conversation. My name is Elena Baer, and I'm joined by my colleague Jerry, as well as our guest speaker today, Claudia Drossel. For those of you who have been joining these meetings over the past few weeks or even past year, welcome back. Those who are new to the call, we are so glad that you're here. We host this 1-hour session on the second and fourth Wednesday of the month. The first half of the presentation is a didactic presentation, and then the remaining time will be used for question and answer. Besides learning from our speakers, you have helped our fellow nursing home leaders on this call. In the past, you've shared resources and strategies, and we encourage you to continue to do so. One thing that I would ask you to do is think about any pebbles in your shoe or things you're struggling with or trying to figure out. If you can send me a direct message in the Zoom chat, or please put your suggestions in the survey at the end of the session, we would greatly appreciate it. Momentarily, Jerry will be putting the link for the PowerPoint presentation into the chat so that you can reference those throughout the presentation. Please use the chat box to share any comments, questions, or anything else that pops into your mind during the presentation, and we'll use that for a discussion in our Q&A. Before we hand things over to our speaker today, I do just want to chat really quickly and send out some reminders to everyone about some recent changes that were made in NHSN for long-term care facility reporting. So the first one is the surveillance section. So several different pieces. You probably noticed this one. I think that began a couple weeks ago now, but several pieces of the surveillance section for COVID-19, that pathway, were removed and 2 new sections were added. One was hospitalizations and the other was not up to date. So I'm going to be posting in the chat after I'm done chatting really quickly a link for where you could find more information on that pathway and the things that have changed, and so that you know exactly what you're supposed to be reporting in those 2 brand new sections. Additionally, starting this past Monday on the 26th, changes were made to the vaccination sections. So the big shift for the vaccination sections was this focus on up to date. So you'll notice a lot of changes when you go in to report for this current week within the platform. So if you haven't taken a look at that thus far this week, make sure you go into NHSN and you review what those questions are going to look like so that you know what to expect when you go to report for this week. Again, there are some really great presentations that have been done from the CDC on those changes into NHSN. So I will put those in the chat as well. Where you're going to find those slide sets and the presentations or recordings that I'm talking about on both of these web pages that I'm going to put in the chat are going to be under training. So take a look at those. And the last thing I just want to let you know about is what it means to be up to date with your COVID-19 vaccinations. So now they're shifting away from the term booster, but you're probably familiar with the bivalent booster in the past. Now we're just calling that the updated vaccine or the bivalent vaccine. So anyone who has gotten the bivalent or updated vaccine is considered up to date. So you're no longer able to get a primary vaccine series. So anyone who for the first time today goes to go get their very first vaccine of any time would get a bivalent vaccine or the updated vaccine, and that person would then be up to date. So just wanted to put that out there to all of you, and I can post in the chat too a really great resource about finding out what it means to be up to date, but want to keep that in your mind so that when you go into report for NHSN this week, you know what to expect and what will be there. And I'll put my email address in the chat here shortly too, in case you have any questions when you go to report. Feel free to reach out to me and I'll be happy to help you. All right, with that, I will hand it off to Claudia and we look forward to your presentation.
Thank you very much. I really appreciate your brief introduction. And I'm coming to you today from Germany, as you hear from my accent. I'm a psychologist and an associate professor at Eastern Michigan University, and I work mainly with individuals age 60 and older with neurodegenerative diseases and their caregivers. Today, I would like to talk to you about behavioral management, and what I'd like to work on is to shift perspective a little bit to the person who has the impairment. So as we start, here is the overview. I have a QR code one more time for slides. We can also use that for resources, depending on what questions you might have and what comes up in the discussion. I want to first talk about the basics, which really is about ruling out delirium. Then about addressing quality of life, which I know is sometimes difficult when you take a person from their home and the person lives in a residential care or skilled nursing facility. And then finally, for the second half of the presentation, I'd like to focus on problem solving and the systematic steps that staff could take, because there is often not a lot of time to take systematic steps. I also would like to give some rules of thumb. And to enhance the presentation, I would also like to show you some client video. These are the learning goals. You will be able to recognize delirium superimposed on cognitive loss, define excess disability, and then describe 3 heuristics for addressing behavioral challenges associated with cognitive loss. In terms of financial disclosures, I'm an author, so I do collect royalties from the American Psychological Association Books Division and also from Springer Publishing. And I've received past funding from the Michigan Health Endowment Fund. We actually received funding for geropsychology education, which enabled us to work with families, which we are still following, where one family member had a diagnosis of a neurodegenerative disease. So we do a lot of home-based care, but in addition to the home-based care, we also follow folks into residential care or skilled nursing, or even sometimes help out with behavioral management in hospital systems. Now, today, of course, we will talk about cognitive loss. And cognitive loss, as you all know, is not part of aging. It's always a sign of a disease of the nervous system. And when we talk about the nervous system, I just would like to point out to you that a lot of people think about the brain, and that, it's very fashionable right now to talk about brain health. And really what we're really talking about is the person's body. If you think of the nervous system, the central nervous system, of course, brain and spinal cord, but you think of the periphery, you think of the enteric nervous system, we're really talking about people whose entire body is compromised. And you can see this, for example, with neurodegenerative diseases like Lewy bodies disease. Lewy bodies disease typically has some gut involvement too, with slowed gut motility and constipation, which can be very painful. And one of the diagnostic criteria for Lewy body disease since 2017 is also a REM sleep disorder. So a lot of people thrash at night and their muscles are not atonic during REM sleep. So again, over and over again, I will direct you to when we talk about dementia, really we're talking about a compromised nervous system, which means that typically nervous systems are compromised in multiple ways and at multiple points, affecting lots of bodily systems. The criterion for major neurocognitive disorder, which is the new term for what used to be called dementia, is that there is evidence of significant cognitive decline from previous level of performance in at least one cognitive domain, based on concern of the individual or standard neuropsych testing or another quantified assessment. Now notice that it says in at least one cognitive domain. So I'm giving you the diagnostic criteria of the DSM-5, the Diagnostic and Statistical Manual of the American Psychiatric Association right here. This means that in contrast to how things used to be, memory loss is not a criterion anymore. So, and as you know, a person with Lewy bodies disease, a person with frontotemporal lobar degeneration might actually have a very well-preserved memory. They can remember what happened yesterday. They can remember what happened a week ago. But in Lewy bodies disease, visual spatial skills are compromised. Vision is basically compromised early on. And in frontotemporal lobar degeneration, what you know is that speech, so language skills for the semantic variant, or long-term planning and organizing may be severely compromised. So the person starts making very bad decisions. So here again, the new diagnostic criteria don't rely on memory as one of the criteria. It may be, but it may not be. As we are learning more about neurodegenerative diseases, you will see less and less emphasis on just memory as a criterion. Now, another thing that has to happen is that the cognitive decline must interfere with everyday activity of daily living. So, and of course, those are often the populations you see. At a minimum, instrumental activities such as paying bills, managing medications, cooking, laundry, and so on must be disrupted. Delirium has been ruled out, and it's not explained by another disorder. That's how somebody gets a diagnosis of a major neurocognitive disorder. You could see on the criteria that delirium must be ruled out. Now, it must be ruled out for diagnosis, but very often it must also be ruled out when the person already has a diagnosis of cognitive loss or a neurocognitive disorder. So delirium is an often overlooked disturbance in attention and awareness. There are lots of quality improvement projects to increase delirium detection in healthcare settings. Those are hospital settings, rehab settings, and then of course, skilled nursing settings also, as you know. The key diagnostic features of delirium are often acute onset, does not have to be, but very often you see abrupt changes in functioning with a fluctuating course of symptoms. So that means when I go into a room and I might give a neuropsychological screener, the person might be doing quite okay during one part of the day. During another part of the day, they're actually not okay. So you see differences in functioning, and this becomes very important when we're asked to do, for example, capacity assessments. We don't want to capture how a person is doing at their worst. We want to capture how a person is doing at their best, and then change the conditions to make sure that a person can always function at their best rather than their worst. What you might see is a lot of inattention and distractibility during conversations also, which is not common in mild to moderate neurocognitive disorder. But you see it much more, this instant distractibility, you see that much more with delirium. You see sometimes impaired consciousness, difficulties to be aroused. And then you see disturbances of cognition. Again, they might be fluctuating with disorientation, memory impairment, and language changes. Supportive features are disturbances in sleep and wake cycle, perceptual disturbances, delusions. Here I want to mention, we will do another workshop on perceptual disturbances separately from this workshop. So I will just focus on other behaviors today. Psychomotor disturbances are part of delirium, unusual or inappropriate behavior, and then emotional changes. Delirium is one of the major reasons for what is termed in geropsychology excess disability. Excess disability was defined already in 1965. People noticed that a lot of folks who have some cognitive loss, they might even have a diagnosis already of a neurocognitive disorder, but they're declining much more rapidly than predicted by the neurodegenerative disease alone. Neurodegenerative diseases typically progress very, very slowly. That makes it difficult for families and individuals because often the decline is so slow that folks don't know, oh, is this now part of aging? Is what I'm seeing clinically relevant or not? But when you see abrupt decline or greater decline than that predicted by the neurodegenerative disease alone, we talk about excess disability. Importantly, excess disability then is reversible or sometimes reversible. Not all delirium reverts to baseline functioning, but usually people improve. And many people with cognitive loss live in conditions that hasten decline, meaning they might be in situations in which they cannot describe anymore their own physiological status. And because they are not able to describe what is going on, while they're completely verbal, they might not get the medical care that they need. To give you a really good example for this, we had a client who had diagnosis of mild neurocognitive disorder, and we asked her about her medical history. She gave us a wonderful medical history, chronological, there were dates there. If we had not ordered her medical records and reviewed those, we would have never known that the history she gave us was actually her deceased husband's history. She had been his caregiver and had rehearsed and spoken about his condition so much that she gave his history to us, but not her own history. And so again, you can easily see that she would, for example, change primary care physicians. The primary care physician would ask her about her history, and she would fail to say that she has rheumatoid arthritis, and because of this, not receive treatment. So again, excess disability is just the circumstance that people might not be able to describe their own medical situation anymore, not be able to describe pain, hyper or hypoglycemia, and because of this, be at high risk of delirium. So the predisposing factors for delirium then are cognitive impairment already. So if there is an already compromised nervous system, if you look at the left column right here, if there's an already compromised nervous system, a person is more at risk of developing a delirium. Past histories of delirium predispose. Functional impairment, sensory impairment, and you might have observed people who suddenly cannot change their hearing aid batteries anymore or fail to charge their hearing aids, and because of this have acute sensory loss. And with acute sensory loss, they look as if they're completely delirious. But then when you put the hearing aid batteries back in, within 20 minutes, they're oriented again. Comorbidity and severity of illness is a predisposing factor. If you have somebody also with a cancer diagnosis, for example, who might be acutely in chemotherapy treatment, depression, history of transient ischemia or of stroke, alcohol abuse, and older age. And then the precipitating factors may be medications, polypharmacy, psychoactive medication use, the use of physical restraints, bladder catheters, which can be intermittently very painful, and then physiologic and metabolic abnormalities can be a precipitating factor. So can be infection, any iatrogenic event, hypoglycemia, for example, major surgery, and then trauma or urgent admission and coma. It's really important to detect delirium, and it's difficult to detect. I want to show you a brief example. I'm going to reshare my screen one more time just to make sure I've switched the sound on, so you can see a person we assessed in the home. And here what we did is we worked with a person to actually check their functional status. And then afterwards, the caregiver, so the spouse, would do the same kind of testing of functional status. And that was just really testing for emergency situations. Can the person give their own name, their caregiver's name, their physician's name, and can they shop at a store? So we set up a fake grocery store, and what you see is that the person is supposed to fetch milk. So I'm going to stop sharing really quickly, reshare, making sure I've got the sound on. Loss. He was at risk for delirium because he had cognitive loss. He had a history of alcohol use. He showed abrupt decline because he remembered her name the week before, could not remember her name with cueing, and then he moaned when he got up. So when I saw this video, I collected the video from the family. I saw this video, I called them and asked the spouse to take him to the physician immediately, and it turned out he had a gastric bleed. So again, the gastric bleed was detected because we paid attention to abrupt decline. So things that were in his repertoire the week before and things that he could not do even with queuing the next week. That's really abrupt. And because of this, we always have to be on the lookout, particularly with individuals who have cognitive loss, who cannot describe what is happening to them. You noticed he was moaning, and even though he had said, I'm not okay, when she said, is your back hurting, honey? He actually said, no, that's all right, I'm all right. So here, catching individuals' decline in functioning becomes a really important tool to rule out delirium, so a precipitous decline that is actually caused by another factor, but the neurological disease. So what we're checking for then is the use of glasses and hearing aids. Typically for intervention, you encourage mobilization. If it's a hospital-based delirium, you review the medications with the pharmacist, you check bladder and bowel functioning. Constipation is a big factor. We often saw abrupt decline due to dehydration when I worked in Nevada. Sleep disturbances are a culprit. And then, of course, to consult with a physician, discontinue bladder catheters as soon as appropriate, manage pain because a person may not be able to describe that they're in pain. So I've seen people, even with fractures, who could not say that they were in pain, but they started having a lot of behavioral problems. And then ruling out infections, and of course, looking for UTIs, urinary tract infections, or inflammation. And then with delirium, the orientation to current reality is usually indicated if the person benefits, and then environmental modifications just to create safety, because it's difficult for the person and the family very often. So these are delirium interventions. So the basics for any kind of behavior change is to rule out delirium, any kind of abrupt cognitive decline, to make sure that reversible factors can be reversed before we decide it is due to the dementia and the circumstances in which the person is operating. So proper diagnosis is important because we always want to make sure that underlying conditions are being detected that may be reversible, and we generate the best level of functioning. So let's say we've done all our delirium rollouts. So we have guaranteed that comorbidities are being managed. We have looked at the data. There is no UTI. Discomfort and pain have been ruled out. Medication reviews might have been done. Nutrition, hydration is fine. Voiding schedules have been implemented. A lot of people feel the urge to go, but might not know where to go, creating a lot of agitation. We have corrected sensory loss. We have put a regular sleep regimen in place. What do we do as the next step if all of this comes back unremarkable? We really have to ask what the person's quality of life is. A lot of behavioral problems are really due to people not being able to continue living in the way that they have been living before. So if the person's current lifestyle honors and respects their preferences, that's really an important determinant of how the person might be functioning. And think about wake and bedtimes, think about privacy, meals and meal schedules. I have a lot of food preferences. I keep on thinking how that might be if I develop cognitive loss. It would be very difficult for me to eat in institutional settings. So finding out how people have lived before becomes a really important indicator for the continuity. Are physical activity regimens in place? Is there access to the outside? So we see a lot of restlessness and a lot of irritability when people might not be having access to the same physical activity that they had before. And I know that's difficult to do in institutional settings. So we've had programs before where we had undergraduate students basically become companions to do activities with individuals in skilled nursing facilities. And they're also used to report to the skilled nursing staff if there were any changes in functioning to catch precipitous decline. Is there regular access to meaningful activities? Are there social activities? And are these activities in line with values and preferences is important? And what is actually the quality of the person's relationships? And here, in any kind of institutional or hospital settings, the person's relationship is with staff. Staff training then becomes all about providing a supportive environment for staff who are working with a severely medically compromised population. And as a shorthand for staff, it's important to know that when somebody's cognition decreases, they might attend much more to facial expressions, to how somebody carries themselves. So what we have seen in one dementia care unit actually was a situation in which a person, a staff member, was left by her boyfriend and she was crying, and there were lots of folks with Alzheimer's disease. And it turned out within no time, we had people with Alzheimer's disease crying with the person, with the staff member. And so very often people with cognitive loss take their cues from staff. For staff, of course, that's very difficult because it almost means that you have to be upbeat. You cannot have a down day. You have to assume that the person will watch you very, very closely. And any sign of stress that you show may actually affect the person's behavior you're caring for. And so staff need a lot of support because their job is very difficult, because they need to encounter people with patients, a lot of organization. So patients to engage the persons in tasks, let them do what they can still do for themselves. Organize tasks in such a way that they are broken down, that the person can have the feeling they're participating. Laughing, ignoring what they can in terms of confused behavior, having a tone of voice that invites people to participate and does not turn them off. And then for people, lots of folks, residents have hearing impairments, also have eye contact when they're speaking to the person. So our POLITE acronym, it sounds easy, but it's actually hard to implement because, as you know, we're all working in high stress environments. And because of this, we teach staff members a skill that we call caring detachment. This idea to notice when you're getting upset about a situation or when a situation becomes difficult, to be mindful and to be able to take a few seconds to collect yourself before re-entering the situation again. Also to notice that it's not your fault, that the other person is probably struggling with something if the interaction goes wrong or the interaction goes south. And if the person does not benefit from problem solving or reality orientation, the resident, staff might use something like compassionate misinformation to give the person an exit with dignity. And so here I'm thinking about situations in which a person might say that their parents who are long deceased are coming to pick them up soon, for example. If they don't benefit from reality orientation, the staff member might actually go with the person. But again, here I would use a caveat. It's appropriate in some situations, but not in all situations, because as I said, we have many different types of dementia, and depending on the type of neurocognitive impairment, and the person might actually know that the staff member is just going along with them. So again, we use compassionate misinformation here and exit with dignity. as only a situation in which we benefit the person if the person cannot benefit from reality orientation. Your staff probably knows that nothing comes out of the blue. So meaning people's behavioral problems, when they develop difficulties, they all are caused. They're not, very often they're not alone due to the dementia. It's the cognitive loss plus environmental situations that make it hard for residents to be oriented. The step-by-step problem solving, if a person engages in a situation, is in any kind of challenging behavior, is like a puzzle. And I arranged it here like a puzzle, but now I want to kind of take it apart in its component parts. So we first want to ask, what actually did the person do? And we train staff to use ing words to actually describe what the person was doing. Is this behavior uncharacteristic? Has it happened before? Does it fit a long-standing pattern? Is it of a sudden or gradual onset? A sudden onset may actually suggest some form of delirium or untreated medical condition. If it's of a gradual onset, it might have been, again, it might have been there for a while, but it might have not become a problem yet. So let me give you an example for this. I was consulted, I used to carry a 1-800 number and for emergencies when challenging behaviors occurred. And so we had in Nevada, basically a 1-800 emergency system. And here we had a situation in which a resident started kissing other residents, which became a huge problem because some residents don't like to be kissed. They don't like to be approached. And so then you, as you know, you have a situation that is really untenable if you get arguments among residents or among clients. So what was the person doing that was creating the problem? Well, she was kissing other residents quite frequently. She had not done it before. What does the behavior accomplish? We actually watched her and looked at her day over time, and we found out that some of the staff kissed her. Interestingly enough, when the staff stopped kissing her, she also stopped kissing other residents. So again, sometimes we have situations that are cued or prompted within the setting, and it might have been perfectly fine for staff to show affection toward residents in this dementia care unit in some situation, but for her, this was not a good idea. So, and then finally, we want to consider the broader psychosocial context. Have the client's roles, activities, and access to family and friends changed? How do family and friends or staff perceive the difficulties? Often we do a preference assessment. An interesting situation was a woman who threw other residents out of bed. And it was a real problem during the night. But during the day, she actually had been a nurse, and staff in a dementia care unit really reinforced and praised her for helping make beds, and which was a really appropriate situation for her. And so for us then, the intervention was to teach her the difference between day and night and make those discriminations more obvious to her. So she would not awaken people at night anymore, but still could work in one of her favorite things to do with the day shift. So again, thinking about people's roles, thinking about how there is continuity between what the person is doing now with dementia and what they used to do previously in their life often becomes a very important tool to problem solve. So we're not treating this as a kind of psychiatric pathology, but much more like this person has been doing things for a long time, and now how do they show up when the person is confused and might not be in the setting in which it is appropriate. So the important rule number one for heuristics is that behavior can be understood in terms of its history and its current context, even when severe impairment is present. And so to give you an example for this, just recently I was called because a woman kept on asking for the telephone, and that was really new in the setting, and she became really insistent. But nobody had really asked her whom she wanted to call. So it turned out that she wanted to call Sears. And when I asked her what she wanted at Sears, and I told her that the stores had closed, I'm in close to Detroit right now, we don't have Sears stores. She said she wanted to buy a nightgown. So I went online with her and we looked at different kinds of nightgowns. And she selected one that looked very much like a 1950s or 60s negligee. And I thought, well, is it something that you would like to purchase? And she said, well, no, I don't want it for myself. I want it for my mother. And then we figured out that the activity person had done a lot of activities related to Mother's Day, thinking that she was preparing the residents for visits from their children. But here, with this very impaired resident, that actually started her holding on to its Mother's Day and wanting to buy her mother a present. So interestingly enough, after we did that online shopping together, and I don't know, I'm sure she did not understand that we actually did not purchase the gown, but the asking for the telephone disappeared completely. So again, she was actually asking for something that was completely reasonable, kind of giving her current context and her confusion. So again, we see this also very often when we have people with visual spatial impairment who might be very fearful. So we had one person who screamed when her wheelchair was wheeled into a shower. And very often with visual disturbances, people cannot tell where the walls start, where the floor starts. They might be very disoriented and even off kilter and balance, even with a wheelchair. One of the staff members, though, said it never occurred with her. And so often then when you work with staff, you find out that one staff member has already the solution, and the solution was to turn the wheelchair around, always wheelchair her into the bathroom facilities backwards, hold eye contact with her, and no difficulties and no problems occurred. Then rule number two, even when a person cannot describe his or her past behavior patterns are likely to be repeated, even when the situation does not call for it. I was consulted because a person was exit seeking. That's what folks told me. He was actually banging on the door and asking to be let out of the dementia care unit. Interestingly, he only did that when we asked when, where, under what conditions does this happen. He only did this when staff left. And this was in the VA. And I actually asked, can staff leave from a different door? These were big double doors. Do you really have to open these big double doors so the shift change can occur? And there was no other solution. Staff had to go through this door. So I really didn't know what to do. And so I thought, well, why don't we try out what he does if he leaves? Because there was no risk. The community living center that I worked in led right onto a hospital ward. So meaning it was part of the hospital and the person would have not been outside. So we opened the doors. He left with staff, but strangely enough, he actually stopped on the other side of the doors and started to shake people's hands as they were leaving. So we don't know what kind of history he had. He might have been a pastor in a church. He might have been a greeter, but that's all he did. And then he went right back inside. So again, other than the description of exit seeking, we didn't have a description, and that was the wrong description. He was not exit seeking. He was trying to continue some task he had done in relations to doors before. Important rule number 3, we need to take into account the person's preferences, histories, and social sensitivities. And so I have a few examples for you. Where often we pathologize behaviors that make sense given the person's context. And when we start thinking about them differently, we actually start to problem solve in different ways. So let me give you examples for that. So often, and this is why ING is so important, people talk about, for example, aggressive behavior. And it is true that the behavior during personal care might look very aggressive towards staff. Problem is, if I now say, okay, the person is hitting and is warding off, having taken their clothes off, the disrobing during personal care, again, might be very difficult for people who, for example, have histories of trauma. And so again, I might problem solve very differently if I think, okay, this person is not engaging in aggressive behavior. She's actually engaging in self-protective behavior right now. What do I have to do differently to create a context of safety for this person so I can approach her and I can disrobe her in a way that becomes acceptable to her? So here I'm talking about really a reframing and a language change, but not to talk about it differently, but to lead to better problem solving and more appropriate problem solving for the resident. If we think about wandering, we had a client who wandered away. She lived with her daughter. She, quote unquote, wandered away from home, but strangely enough, she always ended up in Asian restaurants. She was originally from an Asian country, and she clearly was looking for people who were speaking her language. So again, if instead of wandering, we talk about seeking meaningful events or avoiding unpleasant circumstances, we can actually trying to find out what function the behavior has, what it is trying to accomplish, and then try to get the person what they want. Here, she wanted to have appropriate social interaction. So we could arrange for appropriate language engagement and social interactions without her having to walk away from home anymore, by just simply recruiting somebody who could speak the person's language. So your problem solving looks different if you think about what the behavior is trying to accomplish and under what circumstances it occurs and how it is continuous with the person's history. We're going to do a separate workshop on hallucination, but here, very often what is called a hallucination may be a confabulation. It may be altered perception, and that's what I'm going to talk about. But it also might be a situation in which a person just makes sense out of things. Confabulations we often see when a person is being pressed for an answer. Where is your purse? What did you do? And the person says, well, a little girl came and took it. That's not a delusion. It's just somebody being pressed for an answer and they give the next best answer, so they confabulate. Not any different from what you and I would do if we were really pressed for an answer, but really don't know is not acceptable. The same thing about making sense out of things. We had a person who was referred to us where the spouse said he accused her of having an affair with the dentist. Well, it turned out that the couple had a routine of showering together in the morning that the wife had stopped because she was very uncomfortable with the ostomy bag that the person had and didn't want him to shower under those conditions. And so he basically made sense out of this disruption. The best he knew, accused her of having an affair. But what he was actually looking for was a return to having some form of physical intimacy with his wife. Hoarding or other unusual behavior that we see often is related to confusion or inability to discern rules of conduct or etiquette, meaning we have to problem solve by creating conditions that that support appropriate behavior. And here I'm thinking about a woman we saw who would put continence items in all kinds of locations, and making sure that she could see receptacles for continence items that are appropriate receptacles, then solve the problem. So it was not a situation in which she intentionally, for example, put a continence item into a drawer or under her bed. It was not hoarding. It was just not having a better place to put it. And so again, here I'm really I'm encouraging you to think of destigmatizing these behaviors, thinking about, okay, the person is very confused. They have a neurodegenerative disease. What are they trying to accomplish under those kinds of conditions? So my last rule, number 4, then, is from this perspective, everybody, so people with the neurocognitive disorders and their care partners and the staff are doing the best they can. So we need to support them to make sure that we don't have miscommunication, but both parties really get their needs met. Staff gets their needs met in being supported in the situation in which they're caring for a highly compromised, medically compromised population. But then people with neurocognitive disorders use their tools to accomplish what they need to accomplish. And so we basically help with the communication. Any scenario you'd like to discuss, I'd be happy to discuss. I thank you for your time. I gave you a referral number down here. So we do trainings, and I gave you my email too. Thank you very much. And here are resources.
Thank you so much for that excellent presentation. We really enjoyed it. And I want to open it up for any questions from the audience today that they might have. We'll give people a few seconds. Again, you can post any questions that you might have down in the chat, or you can unmute yourself. I do see one comment in the chat so far from Tabitha. And it was in regard to your one slide that had the information on compassionate misinformation. And she said that she has also heard the term therapeutic lies, meaning the same as compassionate misinformation.
Right. And there are lots of terms out there for the same thing. The reason I do caveats is, think about the situation that I talked about where the woman asked for the telephone. Here, the staff actually tried therapeutic lies. They tried to say, oh, the telephone is broken, you can't use it. So if that doesn't work, it always depends on whether the person benefits. So here, it actually did not work. So when staff said, oh, the telephone is broken, you cannot use the telephone, that did not work. It actually increased her asking. And so again, often our work has to be guided by whether our particular strategy works for the person with dementia. And that's why we really need a big toolbox for staff. And they often, they try a lot.
Yeah, I think back a long time ago, I was a CNA in a facility, and I think back to those times and how beneficial it would have been to have some of this information, because it can be a little bit of a puzzle almost to figure out what is going to help with the problem solving. So right. Like you said, the therapeutic lies versus the compassionate misinformation. Yeah, I think that this is really interesting. And I hope that all of those who are on the call right now might have had some new ideas to maybe help with some of the problem solving in your own facilities.
So I do have a quick question, if that's okay. When we talk about, and I really appreciate your presentation, because it did shed some light, some of the things that I've encountered over the years. But when we talk about individuals that may be diagnosed with some of the things you talked about today. We know that being at home sometimes is a risk, right? Even though it's the most familiar environment for them. And there isn't a lot of neuropsych facilities within the state of Michigan. A lot of times we're sending our patients outside of Michigan to get the help that they need. So is there alternatives to this so that we can make sure that those changes for those individuals don't happen, because we know that changes and sudden changes can exacerbate those behaviors.
Right. So, so are you talking about the transition? Just to make sure I understand your question correctly, the transition from home to a skilled nursing facility or a dementia care unit?
Yes. Yes.
Yeah. So how to facilitate transitions? Transitions are really difficult. And it will, again, the answer, unfortunately, as you know, is always it depends, because it depends on how much insight the person still has. We have transitioned people who really don't have any insight anymore, who have lived at home under very dangerous conditions. And depending on how much insight the person has, that's how we do transitions. So if somebody does not have any insight anymore, we might actually use compassionate information. So for example, with one family who did not want to ever have her mother live in an institution, we had a situation in which we knew that she really cherished the time she had with her deceased husband in a small apartment before they had all their children. And so we said her deceased husband left her an apartment. And when she moved into the dementia care unit, she thought that was the apartment and she loved it. And so again, we used compassionate misinformation here to transition somebody who really was not in touch with reality at all anymore. And it depends. Many people might have enough wherewithal and then be very scared of being abandoned or losing their decision-making completely when they move into a setting. And so, you know, as a psychologist, of course, that's what we work with. So sometimes from my perspective, it's almost easier if you have somebody who is very impaired already to transition that person than to transition somebody who is still extremely worried about what might happen to them when they give up their home. I don't know if this answered it.
No, thank you.
Yeah, so there are strategies, and the American Psychological Association has actually a video out also about transitioning to facilities. It is difficult. I don't want to minimize it. It's very difficult. Yes.
And thank you for that question, Maikisha, and for that answer as well. I know we only have about 2 minutes left until the top of the hour, and I see that Jerry did post our evaluation into the chat. So if you could take a few minutes just to fill out a few short questions for us on how we can make continue to find excellent speakers like Claudia in the future, and find additional topics that are of interest to you. We would greatly appreciate that. But with that, we'll give everyone a couple of seconds here for any final questions. And we really just want to thank you for the presentation today. And yes, we look forward to part 2. I already see some comments in the chat here. And I think that I would have to look at the date of when that is, but that's not our next session. It's in the future, a couple sessions from now. And at the top of the next call, we can let you know when that one is going to be. But
yeah, we talk about hallucinations and delusions.
Yes. Thank you so much. I hope you have a wonderful day, everyone. We really appreciate your time.